how healthcare, in particular hospital as well as frontline medicine, will emerge from the pandemic. Let's be clear, the pandemic is still ongoing, of course, it's not over. Nonetheless, one can look forward with some hope that the arrival of the vaccines and a variety of other interventions means that populations around the world, not everywhere equitably, but hopefully over time everywhere, will be protected from the worst effects of the COVID-19 virus. Of course, it'd be fair to say that never before, at least in my recollection, has health been so central to national and global policy making and concerns as in the last couple of years because of the pandemic. And so today's conversation really focuses on the post-pandemic changes that we would like to see so that we can build more resilient societies, one that is better prepared for future pandemics, but also, while we wait for the future pandemic, one that is better organized to reduce inequities in our healthcare systems that prevail in many parts of the world, improving both the overall quality of care, the evidence-based foundations of care, and very importantly, reducing disparities in access and outcomes to healthcare. I'm joined today by 4 outstanding speakers, and each of them will have an opportunity to present their views on this particular question from their particular perspective. And then we will hopefully have some time for discussion amongst ourselves. I hope very much that my panelists will also feel comfortable to ask each other questions. Of course, I will do that as well. And we will also invite from the participants questions. I hope that there is a way for that to be recorded, I guess, in the Q&A box, and I'd invite you to do that in the Q&A box as well. So let me kickstart by inviting the first of our speakers. I'd like to welcome Ben Osborn, who is the Regional President for the Hospital for International Developed Markets. And I understand, Ben, that is a business of Pfizer, but I'm going to ask each of you to actually say a few words first about yourselves, your particular professional expertise and experience, and then open out into the remarks you want to make today. Ben, over to you.
Excellent. Thanks, Vikram. It's a real pleasure to participate with you all this afternoon. Yeah, just a few words of introduction. I'm a scientist by background, although I've worked for Pfizer now for some 20 years, and I've been right on the front line with our endeavours on both the vaccine and antiviral response to the pandemic over the last 2.5 years. So very much coming at it from that perspective. I'm also the president of the Association of the British Pharmaceutical Industry, a role which I've held for the past 12 months here in the UK. I mean, I think we recognise that the COVID-19 pandemic really is much more than a health crisis. It's in fact, impacted our societies, our economies, right to their very core. And what we've really seen very, very clearly is this close association of health, healthcare, and the economy, and what happens when our health and healthcare systems are challenged. I think according to the OECD, global GDP fell by just over 4% in 2020, really demonstrating that dramatic economic impact. The virus itself has clearly pushed healthcare systems here in Europe and across the world to their absolute limits. It's exposed gaps, it's exposed inequity, challenges, and beyond the enormous impact that COVID had, the pandemic has indirectly caused immense and I think lasting damage by disruption to routine healthcare services around the globe. In fact, I think some almost 40% decline was seen in general healthcare services over the last couple of years. And as healthcare systems have been overwhelmed over the last 24 months or so, we have rightly seen a very short-term focus in dealing with the here and now. However, it's that unprecedented pressure that is likely to have consequences for the vast majority of us, for our friends, for our family, perhaps even for us as individuals, for many, many years to come. And I think it's now absolutely critical that we turn our focus to the longer term impact and the longer term challenges. We know that COVID, unfortunately, is leaving a long legacy. We're daily seeing reports of long COVID symptoms, And as I said earlier on, we've seen many patients, unfortunately, not had the appropriate care over the last couple of years as we've rightly focused on the pandemic. And in such a complex environment, the challenge is knowing, I guess, where to focus and what are the real priorities. As we look forward, a prime example is the importance of increased investment in the prevention of disease beyond COVID. As few countries prepare to execute on their recovery and resilience plans, far too few, I think, are looking at that preventative agenda, and in particular around vaccination plans beyond the pandemic. In fact, in the European Union, for instance, the average spending on preventative care is less than 3% of the overall health spend, and we have some nations spending even less than 1%. We know directly from the WHO, in fact, the Director General, Dr. Tedros, states prevention is not only better than cure, it's cheaper and the smartest thing to do. So what about the future? Well, the COVID-19 pandemic has also demonstrated how innovation can bring enormous value to healthcare systems and our societies in which we live and work. And there's therefore now, I think, a tremendous opportunity to discuss how our healthcare systems can emerge stronger by really building on the lessons learned from the COVID era. The past 2 years have shown us all how resilient we can be when faced with unimaginable challenges. And here at Pfizer, as I said, we've been at the front line of the response. And so briefly, I'd like to highlight 3 key areas that I think we have to learn from. Though unfortunately, history shows us that society often forgets about pandemics all too quickly. We're all longing, I'm sure, for a life free from COVID, but we have to take learnings now. So the 3 key areas I would flag. One is speed. We have to continue to innovate with speed and scale. And we've got to recognize that it's that speed and scale that's going to be absolutely instrumental to overcoming the wider healthcare system challenges that COVID leaves behind. Collaboration. Much of the success here in Europe across the last couple of years has really been down to collaboration between governments, industry, academia, patients themselves, all coming together with the same common goal, the same purpose. COVID-19 gave us that purpose. It indeed gave us a mandate. And again, we need to build on that for the future. And then finally, preparedness. I think most of us would agree we weren't really ready for the pandemic that we faced. And we have to now recognize some of the health inequalities that exist across our nations, the differences between the wealthy and the poor, the vulnerable in our society, and really solve for these as we look forward. And finally, I'll finish by saying improving pandemic preparedness is a global endeavor that really requires a sustained collaboration, as I say, across industry, governments, NGOs, multiple lateral organizations, and others. And here at Pfizer, we're ready now to continue to work with all of those organizations, because we know there will unfortunately be pandemics of the future, there will be health threats, but ultimately we also know, as we've seen through the last 2 years, that science can win. And I'll leave it there. Thank you.
Thank you very much, Ben. You really got us going on some really important points, important questions. And I'm going to come back to you and the other panelists with some questions that arise from your remarks, as well as I'm sure we're going to hear from the others. But what we're going to do is we're going to hear all the 4 panelists, one after the other, to deliver their prepared remarks, and then we'll engage in a conversation. So let me move on to our second panelist, and that's Agnès Soucat. I hope I pronounced your name correctly, Agnès.
Yes.
Agnès, good, all right, thank you. Agnès is the Director for Health Systems Governance and Financing at the World Health Organization. Agnès, the floor is yours.
Yes, thank you very much, and thanks for inviting me. Actually, I was director of health systems at the World Health Organization, but I just moved to the French Agency for Development, where I'm the director for health and social protection. And I spent a lot of my working life in the World Bank, working on financing and governance issues and health systems, not only in Europe, but also in Africa and Asia. And I really want to start with this this premise of this conversation that the COVID-19 crisis has been really an acid test on the health systems we were building prior to 2020. When we look at the pattern of health spending and how the world is spending on health before COVID-19. In 2019, we had 20 years of rapid growth of health spending, and health spending representing about 10% of global GDP. This means that 10% of the global economy is actually the health sector. So the health sector is a very large economic sector, and it is very much driven by spending in the rich world, where about 40% of all health spending in the world is actually happening in the United States of America. So the healthcare industry of the US is very much a driver of what we are spending in health globally. And actually as a share of spending on health overall, low-income countries are representing less and less. So yes, it increases on an absolute basis, but on a relative basis, the global health market is really dominated by OECD countries. What we could see also in 2019 is the fact that the health economy was growing much faster than the overall economy. So while in the developing world, for example, the overall average growth was around 3-4% in the past, in the 20 years between 2000 and 2019, the health economy actually grew faster. Between 5 and 6%. So the health sector is actually expanding globally because on one hand, because of economic growth, because globalization led to countries becoming richer and poverty declining, but also because states organize themselves. So first you see an increase of health spending by households when they become richer, but then states organize themselves and start financing health. And you see an increase in public financing of health. So in 2019, about 60% of total spending on health in the world was public. And that's very important because this means that modern societies have chosen to finance health through collective means, through collective arrangements, either national social insurance or mostly funding that come from government budgets. So the role of people as citizens and the role of governments is very important. Within that, what is not always realized, development aid represents a drop in the ocean. When we're talking about 6.9 trillion being spent on health in 2019, when we speak about development aid, this is about 16 billion. So it's a very, very tiny amount. It's less than 0.2% of total spending. And it has increased in between 2000 and 2020, but that increase has often been offset by a decrease of public spending. That is the only group of countries where health spending from governments has actually declined over the 2 decades before COVID-19 was actually low-income countries. And it was largely because of a crowding out effect, a substitution effect from development aid. So generally, development aid has been incredibly focused on funding products, on funding medicines and vaccines, and has not really contributed much in building health systems. Actually, when we look at the WHO data on UHC Coverage Index, we see that the part of the index that measures progress in health system has become completely flat, and in Africa is actually reaching barely half of what its maximum is. And that is because the density of health workers, the capacity of hospitals in providing services has actually not increased in par with demographic challenges, particularly increasing population in Africa, where the population is increasing very rapidly. It's more than 1 billion today. It's going to be 2 billion 20 years from now. And the investments in health systems are really lagging behind. So what did happen in 2020? We just had this collective shock on health systems been described, in which health system had a really hard time coping with a very brutal increase in demand from people being affected by COVID, and increase in demand on public health systems to design responses to the crisis. And here we could see very clearly that several areas had been severely underinvested. First, it's been mentioned, is the whole area of public health, the commons. What needs to be funded publicly because nobody will actually pay fees for it? That's surveillance, that is regulation of pharmaceuticals, information, research and development on new products. And then we realized that one of the assumptions in global health was that the future was going to be like the past, and that we were endlessly planning global health based on burden of disease of today, and assuming that the burden of disease of tomorrow would follow the same trends it had followed before, which sadly but very clearly Ebola had announced was not going to happen, and it was confirmed by COVID-19. Nobody predicted the impact of COVID. So we need to really increasingly be aware, and as environmental crises are in front of us, particularly climate change, but also biodiversity loss, air pollution, and other environmental threats, that we don't know what's going to happen tomorrow, and we need to invest in much more in the intelligence of the system, in research, development, and surveillance, and really monitoring the threats, whether these threats are biological, physical, chemical, social also, is something that we need to invest much more. And that we found it happened in any country. It was not a matter of income. All countries had underinvested in public health institutions, in the commons for health, that only can happen if there is collective action and there is a commitment of society and citizens, not consumers, citizens really commit to it. It has been really an eye-opener in the sense that even global health had established results framework that were very much about individual services, number of people who have treatment, number of people who use a bed net, number of people who are vaccinated. That's all individual treatments. But there is no result framework currently in global health that look at global public goods, at common goods, that look at investments in the fundamentals of public health, such as surveillance, One Health, including environmental health and animal health, regulation, and other public health programs. So we really need to change that and be able to reinvest the commons and reinvest public health. Second lesson is we found, again, that very little had been invested in health systems, in the foundation of health systems, particularly human resources. What the crisis showed is incredible shortage of human resources, again, everywhere. It was not only in low-income countries, it was in OECD countries that actually hospitals were overwhelmed with cases and had very little reserve in terms of increasing their capacity, and found themselves overwhelmed by the number of people in need. So it's very interesting. Then we see that in many of these countries, health systems had been severely under strain in terms of financing to reduce hospital beds and to limit the growth of health workers, to the point that many countries had established public policies to establish barriers to entry into medical professions in limiting the number of students who can access medical studies, leading to an incredible global shortage of health workers at a time where we have to face those environmental challenges, and we are to face a major demographic shift in the terms of aging of the population. So it is very staggering to see that public policies have failed again and again over the past decades in understanding that we were hitting a wall in terms of not training the number of health workers that we needed. And I'll finish with the last one, which is really an incredible lesson of this crisis, is the importance of social protection systems. When you see the size of this crisis in 2020, when you see that the world GDP went back by 6%, this is much more serious than the 1929 crisis. So if it were not for modern counter-cyclical policies, we would have had a recession that would have taken years to overcome. And yet we've seen that after 2 years, most countries are back into a situation in which jobs are back, economic growth is back. And this is all thanks to mostly OECD countries having established those counter-cyclical policies and being able to channel money to people and to small businesses to borrow as much as was needed to be able to withstand the crisis and keep people afloat and avoiding the complete stop of the economy. And that's the lessons learned for tomorrow. One, invest in common goods, invest in public health institutions, more. We still don't invest enough. And this has been years of neglect of surveillance systems and intelligence systems about the new threats to health. There will be more. We need to understand them better. Second, invest in foundation of health systems. We just don't have enough health workers. And we need to get out of this mindset that we need to limit the training of health workers. We need to train as many as is needed and as will be needed by future crises, who will need community workers to address all the challenges and crises that will come our way because of food insecurity, because of droughts, because of extreme weather events, because of migration. And then third is really established to social protection system. We are just at the infancy of that in low-income countries. Some low-income countries have started to do that. We need to be able to do money transfers. We need to be able to do food for work. We really need to establish those financial systems that will help us withstand the future crisis. Thank you.
Well, thank you very much. I mean, so much food for thought and really interesting, you know, Agnès, listening to you straight after Ben, very interesting perspectives. One, which I think has a lot to do with the healthcare system. And of course, Ben works with Pfizer, one of the most important companies in the world that has also created products for the prevention of COVID disease. And Agnès, you speak a lot about the necessity for public expenditure and the strengthening of government role in healthcare. And I'm sure we're going to turn back to this this question, which I want to just flag up right now for all of us, is this constant tension between the public and the private, and whether health is a public good or whether it's a private good. And I think clearly a lot of variation across countries, especially on how countries really respond to health of the population along these different values. Let me move on to our third panelist, Chris Wolff. Chris is the Deputy Director of the Global Delivery Program for the Global Development Division at the Bill and Melinda Gates Foundation. Chris, the floor is yours.
Thank you. And Agnès, it was really interesting to listen to those comments. A lot resonated with things that we're seeing as well. And Vikram, on the question of public and private, I think clearly the data that Agnès is saying is it's largely, or the majority is public, and there certainly are public functions that can't be played as well by private institutions, and I think COVID has exposed that. So we've seen COVID had this devastating global impact. It showed that a health crisis anywhere can be an economic and social crisis everywhere. And it's clear that the world was really not ready for COVID, as has been said. There were some bright spots. On the one hand, we saw extraordinary collaboration and innovation, the fastest development and most rapid delivery and uptake of vaccines ever. We have our Ben from Pfizer, who was part of that. Many people were part of it. That was really unprecedented. Of course, frontline health workers really becoming heroes for us all, putting their lives at risk, preventing suffering, and really strained due to some of the things that Agnès has pointed out, where there simply are not enough health workers, and there were not enough health workers to deal with the crisis that happened. So there were some real bright spots. And on the other hand, I think we saw that repeatedly countries before the pandemic did not take enough actions to do what was needed to prevent what happened. And during the pandemic, often responded, not quickly enough or not equitably enough to avert a lot of the impact that we ended up seeing. I think we all are familiar with the numerous calls and alarms that were raised before the pandemic that a pandemic was merely a question of not if, it was really when, and that there was a lot that needed to be done to be prepared. And I think we've seen that for the most part, these alarms and these appeals were largely ignored. Investments that needed to be made, like in surveillance, were not made. And then during the pandemic, when tools like vaccines became available, and there was an opportunity to utilize those tools to the greatest public health benefit on a global scale and really manage the disease, we unfortunately saw nationalist policies totally disrupt that, so that the greatest use of the tool that we had was not possible. And as a result, we've lost millions of lives, economies brought to their knees, decades of progress against diseases and like HIV, TB, and malaria were set back. Advances for women and girls also wiped out, health systems severely strained. And I think for me at this point, and for the Gates Foundation, we need, in the world, and world leaders need to pay very close attention to what this means. And I'd like to highlight 3 areas for consideration as we go forward. One is more the short term here and now, and how we move from COVID as a crisis to COVID management. The second is really learning from what just happened and what is happening to actually prepare for the next pandemic. And then the third is part of the learnings as well is building these equitable and resilient health systems and taking advantage of some of the positive shifts we saw when health systems had to respond. They had to, in many cases, get innovative very quickly. And some of those innovations have knock-on effects that help with other parts of the health system that need to be accelerated and continued. So going back to the first, in the short term, the here and now, moving from COVID crisis to COVID management, it's clear that the COVID pandemic is not over, but it has evolved. It's also clear that there is fatigue around the pandemic, a desire to get back to normal. That is understandable. But we also know that there are new variants. There is a possibility of further pandemic waves that will continue to strain the health systems. And there are not every country is in the same place. There are some countries, I think it's about 20 countries that still have less than 10% coverage with COVID vaccines. There are still health workers in many countries who are not vaccinated, and still some vulnerable populations such as the elderly who have not received the full course of vaccination to protect them or the boosters that are needed. And so there is still work that needs to be done, important work that needs to be done, and much of it is in lower income countries. And at the same time, as that agenda is being finished, countries need to navigate how to mainstream COVID management with other preventable infectious diseases like HIV, like TB, like malaria, and integrate the future COVID prevention efforts into the health system. It's clear that management of COVID will be part of health systems and something that country health systems will need to deal with for the foreseeable future. The second thing I'd like to highlight is looking to the lessons, applying the lessons of COVID to truly prepare for the next pandemic. I think Agnès pointed out the staggering economic impact that this has created. Nearly 14 trillion lost from the global economy that's estimated. She was saying, referred to this being, a impact on global economy equivalent to the Great Depression around 100 years ago. Others have said it's the biggest impact since World War II. At this point, there really shouldn't be an excuse for governments to invest billions when it's so clear that those investments can literally save trillions. There has been a lot that has happened since World War II or since the Great Depression. And it's I think, really notable that of all the calamities and crises that have happened over the last 50 to 100 years, the one that it has had the biggest impact is this pandemic, at least in terms of shaking countries, economies, societies in the way that it has. And the investments that are needed are not really big ticket items relative to other spending that governments do. And you'll hear echoes of what others have said on this call and what we see as a few critical areas. And the top one is really surveillance. It's a global system of integrated disease monitoring that some of the pieces exist globally, others currently, others need to be built, and it all needs to be integrated and knit together so that we can better, as a global community, track the spread of disease, monitor for emerging pathogens. And this would include things like mortality tracking, which in many countries, particularly in low-income countries, is severely lacking. And the pandemic and our ability to track the death toll really from the pandemic has been hampered by the lack of these robust registration systems and mortality tracking. We've also seen that pathogen genomic sequencing can be very powerful, and yet a lot of the capacity is limited too much to the higher income countries. And this needs to be massively expanded to all countries really to have that capability. And then all of this, as mentioned earlier, needs to be integrated with existing disease surveillance systems so that we can respond, we can detect and respond more quickly. And then part of that response should be increasing our global response capabilities. We saw a too fragmented response globally. And there's an opportunity to establish more of a professional cadre of expert responders that are linked together, based in countries, located in countries, but linked and coordinated at a global level when an event happens, who can rapidly detect and investigate events when they do happen and contain outbreaks before they're allowed to spread and evolve into pandemics. And then our tools need to be available faster. And this will happen through accelerating research and development on vaccines and therapeutics and diagnostics. We need novel vaccines that can protect against entire families of viruses, infection blocking drugs that can help us contain outbreaks where they start. We need better testing and ability to approve and rapidly approve new products, which did happen to some extent in the current pandemic. And we need to mainstream what were really emergency procedures so that these products can be available much more quickly than we've seen prior to COVID. Global manufacturing capacity needs to expand, particularly in the global South, for things like vaccines, diagnostics, and therapeutics. And we need to think about streamlining delivery systems. Some of the cold chain requirements were, in the initial days, were a real barrier, and in some settings continue to be a barrier for vaccine access that needed to be addressed. And so we either need to put in place the capabilities down to community levels for that level of cold chain, and we need to invest in alternative delivery systems, nasal sprays, microneedle patches, ways that can enable self-administration of vaccines in a way that is not constrained by having trained vaccinators that we see today. And then finally, it's coming back to the backbone of response, which is a resilient and equitable health system. And this health system needs to have trained workforce, as has been pointed out, needs to be adequately resourced. And I think there are a few things that I would like to highlight that we've seen where these trained health systems have innovated in order to respond to the COVID, to the pandemic, that I think are worth accelerating as we move forward. One area is medical oxygen. COVID highlighted that oxygen systems, which is really a function, it's not a product, it's an entire service, that oxygen systems in many countries were not up to the task of meeting COVID, and in many cases are not even up to the task of treating people with pneumonia, of helping mother and child care, of being available in trauma centers. And it's estimated that one recent survey of facilities found that only 10% of facilities in lower income countries had the required oxygen equipment that they needed to address the non-COVID treatments. And so there is a massive need for this. And this is not new technology that's needed. It is simply investment in domestic oxygen, medical oxygen capacity. I'll just give an example. In Uganda, an investment in a new medical oxygen plant at a referral hospital increased their production capacity by 35-fold. So they went from 2,000 liters of oxygen to 70,000 liters available for treatments. And then there needs to be further incorporation of mobile and digital tools. We've seen that those tools have enabled moving services closer to communities and actually closer to individuals. And I'll take some examples that we've seen in Senegal and Nigeria, where in order to reduce footfalls at public health facilities, patients were provided with multi-month supplies of TB and malaria medications. and along with mobile phones. And so that the monitoring and adherence to taking of those medications was shifted remotely. And these were shifts that were already underway and that many health systems had intended to make and intended to scale. And what happened with COVID was that it accelerated the uptake and scale of those sorts of services kind of being addressed in that way. We've also seen an expanded use of digital records, mobile phone reminders, scheduling. In many lower income countries, we've seen scenes of crowds around health services, and with COVID, that was not possible. And so there were shifts to mobile phone scheduling of services for either COVID vaccination, also registries, vaccination registries that were used to send people reminders of when they need to come into the next dose. And these sorts of reminders, scheduling services can be and should be leveraged for ANC services, childhood vaccinations, all of the services that require multiple touch points with the health system. And that really needs to happen at the primary healthcare level and the community level. And I'll end with probably the more complicated challenge in here, which is the need for health systems to deliberately cultivate trust. And trust can be built. We know that there are ways to do that. And we saw from COVID that that performance in COVID was often a function of trust in communities among each other and trust from communities in the health system. And where that trust didn't exist, I think we've seen that the COVID response really struggled. And this is a lesson that in public health and healthcare overall, we unfortunately need to keep learning over and over again. We saw in the Ebola outbreak in West Africa that response struggled until there was a shift with communities engaged in a way that they weren't previously. Ebola victims celebrated, not stigmatized, funeral traditions honored, and we saw some of that kind of play out again with the COVID response. And the way that this trust needs to be built is that health systems need to recognize that this risk communication and connection with communities is a critical function that needs to be paid attention to. That the health systems need regular explanation of services that are available and dependable services that people come to trust. And then when a crisis occurs, the ability to deal with that crisis is much easier when it is built on a foundation of trust. So those are some of the things that we're looking at from the Gates Foundation in terms of moving from COVID crisis management from COVID crisis to COVID management, really truly preparing for the next pandemic through investments in global surveillance, investments in research and product development, and then accelerating and increasing the resilience of health systems by accelerating some of the changes that happen in response to the COVID pandemic and COVID crisis. So I will stop there. Thank you very much for the opportunity to join this panel.
Thank you very much, Chris. Again, lots of very important subjects that you raised here. And I just wanted to pick up on one of those that we'll come back to, I'm sure, in the conversation. And that is the question of the need for global actions, not just in the case of surveillance, but also solidarity in the case of having equity in vaccine distribution. And I guess the real question that I think, looking at the theme of this whole event, the post-COVID approach, is how do we imagine this happening in a future where global fragmentation has happened at a precipitous rate, not least due to the war in Ukraine. which has led to even further separation of nations than I think I can recall, certainly in my lifetime. And that even during the COVID pandemic, many countries right up to this point, not least big countries like China and India, continue not to share any data with about anything really to do with COVID with the rest of the world. And so I think this is a fundamental challenge, where we go to achieve this kind of goal that I think we can all agree is essential, the idea that all nations are united, at least when it comes to the threats posed by pandemics such as the one that we're currently in. Let me turn to the last of our four panelists, and that is Angela Spatharou. I hope I pronounced your surname correctly, Angela. She is the Senior Partner and EMEA Industry Leader for Healthcare and Life Sciences at IBM Consulting. Angela, the floor is yours.
Thank you very much, Vikram, and thank you to all the previous speakers for some terrific themes and introductions. I would just add that I'm also on the supervisory board of EIT Health, which is the EU agency entrusted with advancing innovation and technology for healthcare. So with that hat on, I hope I'm bringing some perspectives also on the role of technology and data and analytics in strengthening the health systems and helping to beginning to address the pandemic, but also create the basis for more sustainable and more accessible health systems in the future. So in that sense, I would like to say that I'm glad all the previous speakers laid out the context and the complications and the huge challenges still ahead, because it falls on me now to talk about the silver lining. And I think at least one of the silver linings, and I think the role of technology, data and analytics is one of these things. I had the pleasure of working, in fact, with the EU institutions a couple of years before the pandemic on cross-border health preparedness and looking at what would happen in a future pandemic, not having COVID anywhere near in our horizon. I remember most of the scenario planning at the time was around Ebola-type scenarios, Ebola-type pandemics, which were, of course, very different to what materialized under the early and later phases of COVID. So I think looking back, upon reflection, what has happened with technology and how technology came to support our response to COVID was totally unexpected, desirable, but unexpected, both in its scale and the impact it has had across the different systems. So what we have seen in the last few years, previous speakers spoke about a lot of the trends, but from a technology, let's say, perspective, I think we have seen a real explosion of data and technology. We know right now that close to a third of the world's data volume is now generated by the healthcare sector, and a big part of that increase has happened in recent years. Now, previous speakers spoke about the scarce resources for healthcare services. I think the latest estimate we had was about 18 million healthcare professionals missing by 2030, taking into account the natural attrition and people retiring. 18 million people globally are missing. We are not training enough people for the demand that we have. And that happens in a context where the demand for healthcare services is also increasing further than it is today as our population ages. And that was one of the observations we saw accentuated during the pandemic as well. Then in the last few years, we've seen a significant growth and change in the role of the non-traditional providers. So a lot of the digital health players and the creation of digital health ecosystems, trying to create the first point of response to give people access to advice on COVID and over time access to remote care in cases where they didn't or were not able to go to hospital. But also we have seen a change in the relationship of individuals with the healthcare system, in particular across the globe. But if I think of Europe as an example, a lot of people have now gotten used to accessing healthcare digitally, remotely. And that has happened much faster than we were expecting was possible, and across generations, not just the younger people. But at the same time, that has put healthcare for the first time in a level comparable to other digital services. So it has created unexpectedly, or expectedly, I guess at that point, an increase in what we call health consumerism. People looking at the healthcare service as consumer goods in a way, and trying to improve or expecting an improved access to the health service, the same way they would expect an improved access to other digital services. So all of these things have created a set of new parameters in and around the technology aspect of our response to the pandemic that I think are quite interesting. Now, we spoke a lot about the lack of financing at the global level, and I think that is a huge theme. what we see in EMEA, and in particular in EU countries and the UK, is that for the first time in recent years, healthcare is becoming much more of a Treasury or Ministry of Finance issue than ever before. Not that it shouldn't have been before, but for obvious reasons, it has become much more now than before. And we have seen interesting amounts of funding. To begin with, if I think of the EU, coming from the EU into health systems and into different countries, in some cases dedicated to health programs. So the EU4Health program, from memory, over 5 billion. Some aspects of the Horizon Europe program, Connect Europe, etc. These are all multi-billion programs. But we have also seen thoughts dedicated to digitalization and innovation in healthcare and strengthening health systems coming through other pots of funding, such as Digital Europe or Next Generation EU. Again, different pots of multi-billion funding going down to the different countries and their health systems and being available to be used to improve the digitization and accessibility of the system. But in a way also then connecting with the recovery funds, another big pot of money coming into the countries. And in many cases, like in the case of the UK, of Germany, France, Spain, and other EU countries, with much funding from the country going into hospitals in particular, but also other parts of the system. So in that sense, we have now a lot of momentum around, first of all, an underlying understanding that we want to invest in health, and there is some money available, and people are using that momentum to increase their investments and to grow their collaborations. And in another level, also the ability to do so, including connecting people and data in ways that we were not able to do before. So what I'm going to do just for a minute is to share my screen. I'll share just two examples of what this has looked like in practice and why this has been important. I hope and trust I'm able to connect my screen, and you let me know if you can see that. So, yes. So assuming you can all see my screen, if you can't, please let me know. The first example I wanted to use is how data and connecting data from different areas was used in life sciences and in our broader pandemic response in the last few years. These are some examples from the UK that I had available. There's many more in different countries. But the important thing here is there's two themes. One of them is if you look at the work that Health Data Research UK, DigiTrials, or the Recovery Trials did, was basically very quickly connecting data faster than was ever possible before in the UK. To look at different elements such as different treatments that pre-existed, to what extent they could be used in the fight against COVID in hospitals. So for example, you may be aware of the work that was done on dexamethasone, which was an anti-inflammatory used for a very different set of conditions. It was tested through these mechanisms in the UK, and people reached the conclusion very early that it was something actually that was useful in the response against COVID as a drug to be administered in hospitals. That's just an example. There are many more, and clearly for any one conclusion that worked, there were many others that were discarded, but that's part of the scientific process. The second theme here is that countries, and here's the UK example, used the momentum during the COVID period to strengthen their health systems in different ways. So if I look at the work they're doing under the UK Health Security Agency, the work there comes back to one of the themes that previous speakers mentioned, how to strengthen our resilience and responsiveness and surveillance for the pandemics of the future. So one of the key questions this organization is asking themselves right now, and it's a new agency, is what should the Health Security Agency of the future look like? And how does it connect with the ecosystem around it in terms of global bodies, donors, and others that can help speed up our response? The second part is Genomics England, again, similar efforts in other parts of Europe, but looking at how to take this momentum around connecting and sharing data and use it to personalize care and give people access to genomic medicine as part of the mainstream delivery, even at the level of primary care in the UK and similarly in other countries. So these are investments for the future. These are not blip funding that will go away once COVID has passed, but actually ways of strengthening the health system that are here to stay. The next example is some very significant work that happened in the background around connecting data with the patient at the center. So this is, again, one example that's from Germany. There was a significant effort in Germany, actually preceding COVID, but significantly sped up during COVID, on building the German electronic patient record, building the backbone for a universal, interoperable, secure ecosystem. This is the example of IBM was participating in a part of this. So the part that IBM participated in ended up connecting the data of 30 million patients, but there's other parts of that system. It's a national effort, definitely. But what's interesting here is that for the first time, it became an expectation with a lot of regulatory and government push, let's say, to connect the data of the patient across the public sector, primary, secondary, tertiary care, private health insurance where appropriate, pharmacies, different types of care providers, including digital health providers and so forth, and creating all the layers you see down there for that work to be possible. Again, this is something that as an idea existed, some of the work had been done, but the acceleration we saw in this type of connectivity across EMEA, and in fact, not just in Europe, but also in the Middle East and other places in EMEA, has been pretty significant in that time. The last thing I'd like to mention here is we didn't speak much yet around social care, but I know this is a very big part of the equation. So this is an example of some of the work we did actually in the US, but the important thing here is we cannot have the outcomes we want, and we cannot strengthen the health system the way we expect if we don't connect health and social care. We have clearly moved past the stage of episodic access to care where someone, I don't know, breaks a leg, goes to hospital, the need gets addressed, goes back home. We are now at the stage of how do I manage to support people on a chronic basis to live as healthily as possible for as long as possible in their life. And for that, we need to address social care. We need to address the social safety network and what we call the social determinants of health. So you can see to the right of this page some of the example services we try to connect, which in the case of the US example were daycare, food, housing, employment, education, counseling, and so forth, even transportation. So all of these things are very important. The problem that we have in the UK and other parts of Europe is that the data in social care are probably a little bit more difficult to access. In some cases are less digitalized than the data in healthcare. In both cases, we still find paper records, but in social care, we find a little bit more. So actually there is much more foundational work that needs to be happening so that we can connect social care and healthcare in a way that can help us really strengthen our health systems. So I will just close by saying, what does this mean in my mind for the future? First of all, if I stick with the technology theme for a minute, I think there is a big amount of work to be done to build on the momentum we have to not go backwards, to keep investing in the right technologies that can create innovation, that can help towards population health management, that can help towards more personalization of care, and make sure we identify very clearly and share the narrative with Ministers of Finance and others on what are the highest return on investment cases that we need to grow. And when I say return on investment, I don't mean just financial. It can be return on investment in terms of significantly better outcomes in a particular disease pathway. In whatever way we define return, but actually showing impact, I think is quite important. Another thing that is important in the case of growing how we transform care through technology, data, and analytics is what we call the war on talent, the war of talent, let's say, which is the professionals we need to make this happen are highly sought after. It's extremely difficult to recruit across Europe right now in different parts of technology, and it's the same for the health systems. So we need to create exciting career paths for people with the right skills to come into healthcare and actually stay. And if I move outside of the technology area for a minute, and coming back to some of the themes people mentioned, I think we need to work much more systematically around improving access and patient experience when accessing the healthcare service. And I think digital has a big role to play there, but also creating user-based clinical pathways in a much more systematic way. I think that's quite important. I mentioned personalization and population health, and I think we also mentioned security. The two final themes I'd like to mention is patient engagement. So again, using technology to grow patient engagement in a way that allows both patients and their carers to connect with the system, understand what is available, care for themselves in the best available way. It has been proven again and again, and there's a lot of clinical studies that patient engagement actually improves outcomes and makes care more effective, and for cash-strapped health systems more sustainable as well. I think that's a very big priority. And last but not least, I think we have not mentioned, but it's huge in my mind, antimicrobial resistance. This is one of the areas where there was a lot of discussion before COVID and a lot of funding going through different things. The funding was nowhere near enough. Anybody who knows the topic, if I ask them what keeps them up at night, that's the #1 thing that keeps them up at night in terms of underinvestment and the combination of low investment and huge risk. So as we think about investing more in healthcare, I would love to see more happening in this space as well. Thank you, and look forward to the rest of the discussion.
Well, thank you very much, Angela. So many different themes have emerged here, and I'm going to invite now everyone to sort of just unmute themselves and respond to some of the big themes that I would like to sort of discuss from here on. And also, I would invite all of you to, feel free to ask each other questions as well. There is a hand signal button on the Zoom, which you are welcome to use, or else you can just simply unmute and speak when you see an opportunity. I also invite the attendees to use the Q&A box to insert any questions you might have, either for anyone on the panel or for specific individuals. If you do so, please use just identify who you'd like to respond to your question. So many big themes, and I want to just touch on about 3 or 4 of them in sequence. The first important theme that's been raised is to do with, let me see which order I want to take. First of all, let me just take the order of healthcare providers and the architecture of the healthcare system. Many of you have spoken to something that we've all witnessed in the last 2 years, and that is what began as an epidemic with an incredible emphasis on tertiary care. We can all remember, the ventilators and doctors in white coats and, all of that, with a huge emphasis on pharmacological products. This is, of course, in the pre-vaccine era. We now recognize that, in fact, like any other public health crisis, the real foundation of the control strategies lies in the community, through not just community health workers, but engaging diverse sectors in the community. And that has been, of course, a transformation in virtually every single country in the world. And I heard many of you speak about frontline workers, community health workers, the foundation of our healthcare system, and so on. And so the real question for all of you looking in the post-COVID era is, where do you see the maximum investments taking place or should occur in order to rebalance what I think is currently a heavily imbalanced healthcare system, particularly in wealthy countries, focused at the top of the pyramid of care rather than on the base of the pyramid of care, primary care, community health workers, and so on. Anyone?
Vikram, I'm happy to start. I mean, I think I alluded to some of the stats. I mean, they're just staggering in terms of the amount of capital that's invested in cure control disease rather than prevention of disease. And for me, that's where we've got to begin. We've got to look at that equation. How much money is actually going into prevention of disease, and dramatically increase that. I recognise that can't come at the expense of overall increase in funding, because we're in many countries under real fiscal challenge, but we've got to better invest that money. We saw that firsthand during the pandemic, and we saw as we're coming out now, the opportunities to tackle that. I think then many of the major diseases, cardiovascular, perhaps some of the mental health, oncology, we know there are preventions that can be made, and now is the time to do that. And that will not only relieve the burden on secondary care and tertiary care, but I think also on the front line in primary care and GP surgeries as well.
Absolutely.
And I think the final part to that is, I think a big part of it also requires a sort of an education of our society and what our expectations should be for how we receive and where we go to for healthcare. I think it's going to look dramatically different in the future. I personally haven't been in a GP surgery for 2 years, yet I've received healthcare support services digitally that have been just as good, if not better, because I've been able to get an appointment within hours rather than weeks of when I would ordinarily have received that care. Most of the diagnostics have been done virtually as well, or at least the results read out virtually. So there's massive opportunity there, but I think we all need to adjust to what the past was is not going to be the future, really.
Yeah, well, actually, yes, go on, Chris.
Well, I was going to add, it's clear, the need is clear. And at least in some of the lower income countries where we've been working recently, one challenge that I think needs to be addressed is the discussion between health and finance. And Agnes, maybe you know, from your World Bank experience have seen this, but whether we collectively are engaging ministries of finance in productive ways. I hear over and over again that finance ministries aren't convinced that the funding in health is well spent. And somehow, you know, that case isn't being made. And so there's a big disconnect between a clear, massive need that's been highlighted by the COVID, you know, crisis, and the level of kind of commitment and that the ministries of finance have to actually meeting some of the needs that are there, and somehow that needs to be bridged.
I agree. I mean, what is clear now is that we have entered an economy in which care is incredibly important. And I think that's going to be the next challenge, the economy of care and the link between that economy of care and social protection. It's economy of care because we have most of the world is going to age, right? And 20 years from now, there will be only one region in the world that will have a young population. It will be Africa. The rest of the world will be going through a complete shift of its societal equilibrium, with a very large proportion of the population aging and a decline in population. And the question will be care. Already for the young population, the question is care in a world where there will be less labor, and women in the labor market will need assistance to care for young children. So again, a social protection question, a care question. And that's the one of the major shifts, is to think about the healthcare sector as a care sector rather than as a product sector. And when we look at the life expectancy gains, we've seen that in absolute, we have reached the limit of life expectancy gains. And actually, there's a lot of questions in advanced economies about the quality of life of those last years of life expectancy gains, because we've been focusing on technology, we've been focusing on products, and we haven't thought enough about the kind of society we want. And this is where the question of community health is extremely important, is the question of how do people live in their communities, and what is the role of health and social services there in providing assistance to them, either at the end of life or during the times of their life where they face chronic disease, or at the time of crisis, such as the one like the pandemic, or what is going to happen in many places of the world, which will be extreme weather events or droughts or food insecurity, and societies are disrupted. So what kind of health services and social services, what kind of adaptive systems, adaptive health systems, adaptive social protection system will be there? And the answer, you know, it's not that difficult in a way. The answer is, of course, human capital. It will be people who will have to make up new solutions. And when we look in the era of product, what is fascinating, what happened, which is absolutely fantastic in this crisis, is in fact we can see that we can develop products very quickly. And we don't develop products that necessarily cure, but we develop products that mitigate. And that has been the pattern over and over again. So the question of R&D and the commons is essential, but at the end, the question is mostly is about systems who care for people and adjust to their needs. And we see it with the vaccine issue right now. It's been really fascinating to see how the global health community has focused on the wrong problem. For months and months, almost a year and a half, has focused on the money issues. Oh, it's a matter of money. It's never been a matter of money. It's been really a matter of managing a situation in which there was shortage, and then thinking about the market failures, and now thinking about how health systems that will deliver products that people need. So there is really a shift that needs to happen in our collective thinking. That is not about throwing constantly the question of money. Money is important, but money is ultimately what is important in the question of money is how you use it. There is no lack of money. The question is how to use it, and the fact that we think that the only answer to any health problem is to buy a product and distribute it has proven wrong in this crisis. Because a lot now is known that a lot has to do with ventilation, it has to do with public health measures, and when a product is available, it has to do with how the production of this product and how the regulation of this product takes place, and what is the role of state versus markets. It's not been a question of just raising money. There has been money all along in this crisis, and the question is, how do we manage better the common purse, the common pot? So if we put money together at national level, at regional level, at global level, how do we use it? And I agree very much. I mean, there was a point in one of the speakers about a world that is increasingly multipolar. Clearly, multilateralism is in a crisis right now, and it doesn't look like things are going to get better. But there are ways. We see other forces emerging, as you mentioned. There's a lot of things that have happened during this crisis. Nothing has happened from a centralized standpoint. Everything has happened bottom up. We've seen scientists from South Africa informing the world directly. We've seen scientists publishing preprints of their research. We've seen information being shared in real time. We've seen regional institutions such as the Africa CDC emerging out of the crisis, or the European CDC and European Public Health has emerged out of the crisis. It's like cooperation is happening in a different way. We're not in 1945 anymore, and the post-World War II order is reorganizing, and it's going to be reorganized in a very different model, much more on a model of networks of knowledge, networks of citizens and practitioners, and more like confederation of regional mechanism or sub-regional mechanism that aggregate in different forms and different ways. And if there is, in my view, one lesson about the world order that this crisis has taught us, is centralization doesn't work. It's really about much more horizontal mechanism.
Thank you, Agnès. Several things again that you raised there, and I think in particular, I want to circle back after Angela has her comment on this big fundamental question that you raised about systems which care versus systems which commodify health. I think there is a big issue here. And I think when you remark that we have enough money, this is, you know, I'm reminded of my my late chair, Paul Farmer, who used to often say the issue in healthcare is not about money at all. It's about how much we value health and how much we are able to allocate money that exists in the system, but we spend it either on inefficient things or on different things and put it behind health. There's never been a question of money. And as you rightly point out, countries around the world have often spent sometimes more than their whole health budget on just the vaccine purchase in the last year. So, you know, the fact that there is money is completely evidenced by the fact that countries were able to raise billions of dollars around vaccination, which they supposedly never had to actually invest in the foundations of the healthcare system until they suddenly discovered that money lying around. Angela.
Thank you, Vikram. So I'll just start by echoing what you just discussed about money that is available and the use of that money. Prior to working for IBM, I was with McKinsey & Company in different global health roles, and one of them was being lead for LATAM, healthcare services out of Mexico City. So one of the first things that struck me is that I arrived into the region thinking, oh, wouldn't it be amazing? You know, we've seen so many exciting things in other parts of the world to bring them into the region, but what a shame, you know, that the funding envelope is so different. And one of my first realizations a few months in was that exactly your point, that there were pots of money in different parts of the systems, and I was covering anything from Mexico to the Caribbean down to Chile, right? There were different pots of money, but the way they were used in many cases was without a plan as to what outcomes you're actually trying to prioritize. Clearly, everybody wants to improve care in any possible way for everybody all the time. But within that, how do you actually prioritize to deliver specific impacts in certain timeframes? That was quite often the challenge. Now, to your question, where to put the money? I would start by saying, I think there's still significant work to happen in hospitals, not to grow them necessarily, but to actually connect the hospitals to the rest of the world. In many cases, what we saw in the pandemic is that some excellent organizations operated almost like islands. So centers of excellence in an ivory tower, but not actually connected to the health systems around them in a way that in fact would strengthen the rest of the system as well. So there is a lot to be done using technology and other levers to connect these excellent organizations with what surrounds them, and then create a more of a health system approach at the local level, at the, you know, at the city level, at the borough level, at the region level, before you get to the national. So I think there's something to be done there for sure. But between the different settings of care, I would come back to, I think it was Ben who mentioned it earlier, primary care for sure. In many cases, the primary care might be very effective. In others, it may need to change. But fundamentally, what we see there is at any given time in most health systems, more than 2/3 of the interactions of the patients with the system in a given year tend to happen through primary care rather than hospitals. It is a very big part of what happens in different systems across Europe. And that includes then the ability to act more programmatically around different chronic diseases. So manage populations in a different way and help improve outcomes for everyone. But also can include aspects that we're not currently touching as much. So you mentioned, I think Ben also mentioned mental health at some stage. Mental health is a very good example. At any given time, again, more than half of the cases that we see in the system tend to be common mental illness, anxiety, or depression rather than severe mental illness. A lot of common mental illness can, and in many cases is being handled in primary care. But that also means then that primary care needs to have a different level of specialization and different abilities and ability to actually track these type of patients across the physical health, mental health facilities and social care and the benefit system quite often, and be able to have an integrated approach around these patients. So for me, it does come down to how do we strengthen primary care, both in terms of how practitioners focus on chronic disease management and on population health. How do they understand their population? How do they segment it? And how they prioritize different types of interventions for different parts of the population? And then how can we support them with the right information and data and systems so that they can track how the patient develops over time and support them not just reactively, but also preemptively. The last comment I wanted to make was how we can make the case for investment, coming back to some of the comments people made. I think we have done a lot to show the impact on mortality, let's say, if you invest in healthcare in certain ways. I think we have done quite a bit to show the impact on keeping people out of hospital and taking care of in the community if you do certain things right in primary care or other non-hospital settings. What I think we haven't done enough of, and I have seen a lot of the finance ministries and people in the finance sphere reacting more positively to even, is looking at how you can support the population to live productive life as long as possible. So not just from the aspect of, oh, wouldn't it be nice if we all were healthier and happier, but also from the aspect of, and by doing so, you actually can have a very productive and energized workforce for a longer time. And given what I think Agnès mentioned earlier about aging, and the only region in the world that in a few years will not be aging, but still have a young population being Africa, I think for the rest of us outside of Africa, that is a very big deal. If you have to deal with the population you have, keeping it as healthy as possible and as a productive member of the economy as possible should be a priority, I think, also from a finance perspective, not just from a healthcare perspective. So hopefully this completes the set of arguments we can make to show the real value of investing in our health systems.
So I think this leads to the most obvious, the elephant in the room. What is that health system? And, for a long time, nations of the world, and particularly led by the World Health Organization, have spoken about the concept of universal health coverage. And it's something which, of course, is enshrined also in the Sustainable Development Goals. Are we all speaking about that? The need that all countries need to invest in a universal health coverage system, typically that's grounded in certain fundamental principles. Perhaps the most important one is that the state acts as the steward of the healthcare system, that ideally there's a single payer mechanism, that even where there is a strong private sector, that the private sector operates as part of a national healthcare system, like you see, for example, with the GP network in Britain, or indeed in many European countries where there's a strong private sector, but within a universal health coverage framework, which includes regulation of costs, accountability, and so on. And most importantly, of course, is that there is complete financial risk protection for people who are seeking healthcare. It sounds to me that all of us are speaking about UHC, something that is absent in the US and indeed some of the other big countries in the world like India, which accounts for the enormous levels of inequity, disparities, and impoverishment that you associate with healthcare. And in fact, just simply not seeking healthcare at all because you simply can't afford it or you don't trust it. And so I think what I hear all of you saying is a call for universal health coverage. And I wondered whether any of you has any thoughts about the single biggest obstacles towards achieving universal health coverage, particularly in countries like the US, in many developing countries of the world, where this still seems to be something very far away from the reality of how health systems are being financed and structured.
I'll be happy to start that with a bit of a provocative statement. I think is what we've learned, again, when you give the example of the United States, is that universal health coverage is not a money matter. The US is the country that spends the most on health. The US government is the government that spends the most public money on health services. And yet there's still people who have difficulties in accessing the most basic healthcare in the US. And the fundamental obstacle is very definitional. Is for universal health coverage is a collective objective. It requires social cohesion. It requires a societal project in which you have a level of homogeneity in the population for them to agree to cross-subsidize. It means that everybody in that society is willing to pay for the other. It means that rich people agree to pay for poor people, that white people agree to pay for black people, that somebody who speaks a language agrees to pay for somebody who speaks another language. Somebody who has a religion agrees to pay for somebody who has another religion. So it requires a social contract. It requires homogeneity. And the more heterogeneous the society and the more fractures you have in society, the less easy it is to have universal health coverage. And of course, just the fact of pursuing universal health coverage, which requires a collective project, which requires gives and takes, which requires building something in common, is helping in building that collective view. And And building universal health coverage is part of building a nation, building a society, because it has this redistribution effect from healthy to sick and from rich to poor. And that's the single most important obstacle, because we see it, as I was mentioning in my introductory remarks. It is fascinating to see that over the first 2 decades of the 21st century, the public money going to health as a share of government money went down in low-income countries, right? So that means the formation of that collective vision did not happen. And that's also because, in fact, it seems to me that there is a misunderstanding of what universal health coverage is, and when global health is pushing its own way and its own approach to what they define as universal health coverage, you already are bringing something that is contrary to universal health coverage. If the definition and the modalities of universal health coverage are defined in Geneva or in New York or in London or in Paris for that matter, and not in Nairobi or in Pretoria or in Mexico, then already that's not universal health coverage. And I think there's been a big misunderstanding in the global community to confuse the global health programs that are like the global health efforts at vaccinating or providing HIV treatment or treatment for TB, confusing that with universal health coverage. It's two completely different goals. And the challenge we have today is how to reconcile them and how to allow the space to countries to build their own national systems without imposing them the way to go about it. For example, in fact, when you look at what has happened in India for the past decades, we've seen that actually people have really paid out of pocket for primary care. So that's what they want to do, right? They value healthcare and they want to use the private sector. So if we want to do otherwise, then you need to have a conversation. You need to have a national conversation about it, because most of the financial protection problems happen at hospital level with very high level of expenditures. But yet we often come with the recommendation of publicly financing primary health care, but that's extremely difficult. It's requiring a level of intervention of the state that is extremely high to really ensure the proper quality of primary health care in all of India, right? That is publicly funded. So we don't always realize the kind of societal complexity there are, and that there may be different pathways to actually reaching that kind of collective project that is UHC. But that's for sure UHC is a factor of social cohesion, of social trust, that is extremely important in the building of a society and in the building of a system that will be able to adapt to future crises.
Thank you, Agnès. I think on the question of trust, and also we have a question from Laura in the Q&A box. But let me first turn to the question of trust, because that's something you just raised, Agnès. And of course, some of the other panelists have also spoken to this very important issue. That is to say that something that we've all witnessed in the last 2 years has been the explosion of mistrust, not least between large sections of the population and the state, government advice, for example, and also of the scientific community. And I think, of course, the best example of that is to do with vaccine denial or hesitancy, but also to do with other kinds of mandates that governments have tried to impose in order to control the spread of the epidemic. For example, the use of masks, and also on the contrary, when certain governments have actually said not to use certain kinds of medication. I recall in India, in the US, not to use ivermectin. Many physicians and indeed even some politicians themselves promoted it, and vice versa in India. So I think the question of trust is what I'd like to turn to. And you talked about social contract, which of course implies, not least, that there will be a degree of trust between people for each other, but also very importantly for their elected leaders. And I wondered whether anyone had a comment about looking ahead in the post-COVID era. What are the lessons that we can draw that actually require us to reimagine how we build societies in which people not only trust each other, but very importantly, trust the government in the recommendations that government is making. And let's just stick for a moment to health. Let's not get into, there are many other areas, of course, about trust, which one can talk about. But in the context of this, this particular discussion, let's just focus on health, about government recommendations on, what treatments people should take, how they should behave, et cetera, to control the burden of any health condition in the population. Does anyone have any particular thoughts on that? Yes, Angela.
Sorry, I was trying to raise my hand electronically as well, but I wasn't fast enough. There is a couple of things there. So one of the discussions we had in the UK and other parts of Europe recently was around trust in the system, for example, around sharing of data. And there were a lot of focus groups and panels and, bringing patients together and asking this kind of questions. And I think that's an example in the topic of trust. What we found was actually giving people a very clear narrative on why certain things are important or helpful and what could this mean for them, for their own health, for the people they care about, or if they're patients, let's say in a rare disease or a particular cancer area as an example, what could it mean for others like them to do certain things? Personalizing it and showing people the value to them and their communities and people they care about seem to be very important. That implies transparency. That implies having a clear vision as a system of why you want to do certain things and having the ability to communicate it. But I think trust in what the system does is one thing. And I think in Europe still, and in the UK as an example, there is a lot of trust still to the concept of the GP or the clinician, as a sort of a neutral broker of care that is trying to help you in the right direction. I think there's another element, which is how do you empower patients and their communities to really go further than that, not just passively receive what a clinician or a clinical team or a nurse or others tell them, but to go more proactively towards what do I need to change in my behaviors, in the way I connect with the system, in the way I think about my nutrition, my exercise, my mental well-being, so that over time, I take care of myself in a different way and I help people around me, my family or my community in a different way. So I would like to just have both of these sides of the puzzle together.
Thank you. If there's no other comments on this, let me ask if anyone would like to respond to the question that's raised by Laura, which in just summary is how can we all agree that prevention is better than cure. This is one of those old kind of axioms. Yet, of course, prevention, of course, is a complex subject because a lot of prevention in healthcare occurs outside the health system. Let's first of all acknowledge that. And that it's quite likely that when we talk about spending and we're looking at the balance between prevention and treatment, honestly, a lot of the prevention work would not even count within the healthcare budget. For example, consider access to safe drinking water, clean drinking water, or to sanitation, which is perhaps the best examples of prevention. But I guess, Laura, what you're really speaking to is prevention that can be done from within the healthcare sector. And a good example of that, of course, would be could be immunization. So the question is, how can we collaborate and help governments invest in prevention rather than perceive it as a cost? What should we focus on to make this shift possible? I certainly, I would say one of the most important things that we need to, stakeholders we need to bring on board for the healthcare sector is physicians and other care providers, because for them, there's not much in it for prevention. Prevention is a time-consuming activity sometimes with very little value addition unless you get specifically reimbursed or have time allocated for prevention work. And certainly this is one good reason why systems in which providers are reimbursed for services delivered rather than for per capita payment systems, typically you will find oftentimes a combination of the irrational use of interventions for the treatment of health conditions and a very low level of engagement with prevention activities. But I wondered whether anyone has any response to Laura's question.
Vikram, I'll offer a couple of points. I think for me, I think it starts with reframing the mindset around health at the very highest levels of society and government, and that is that the health of a nation moving forward is a genuine asset, and we need to look at the health of all of our nations now as an asset. And when we shift towards more asset investment and management rather than a cost to bear, I think you start making some very different long-term decisions. And I think it's really, really important that we all recognize, and there's an open, transparent conversation, that many of the investments in prevention take many years, if not decades, in terms of then the value that are delivered. But the value is unquestionable in terms of health gain. I think what we need to recognize, though, is that many of these investments and policy decisions will be over a longer time frame than many political decisions are made, and that's a tension that exists, and we need to, I think, face up to that. I think we need to be open and transparent and really acknowledge that, but then challenge ourselves and challenge governments to be investing for the longer term gain that may be beyond the tenure of their government. And I realize that that's not always comfortable, but I think that is what it is really going to take. I think the second piece is it is really going to require cross-government, cross-department alignment, as just mentioned. This is not just the responsibility of health. This is going to involve education. It's going to require transport. It's going to require social care. It's going to require almost every aspect of government playing a role and asking themselves what is their role in improving the health of the nation from birth right through to end stage life.
Yeah, well, absolutely, Ben. I absolutely agree with you there. I wanted to circle back. Actually, one of you made a mention around mental health, and I just wanted to say, you know, that's actually the area that I work in, and in fact, you know, I can't remember who raised this question, this observation really about the effectiveness of community resources for prevention and care, not just prevention, but also the delivery of evidence-based brief psychological interventions for mental health problems. This has been the bulk of my work over the last decade. And what that really shows is how one can address as many of the questions we've talked about here, addressing health holistically, not just disease by disease, in a person-centered way. So you address the needs that the person has, which is often far more diverse than simply a diagnosis. And that includes, of course, mental health difficulties. The second is the deployment of existing resources in the community, rather than sort of having to say we need to train a very expensive providers or import them from elsewhere. These are all relying on locally available human resources. Attention to training, which is typically competency-based with very clear structures for supervision and quality assurance after the training. And ensuring that these community-based models are working in coordination with the more clinic-focused and hospital-based systems, recognizing that one size does not fit all, and you do need to have a continuum of care for most health problems. And I think what this allows us to do is also think of health problems in a continuum, from prevention and promotion at the one end of that continuum, in which you are also including early intervention, I'd say, through to treatment, which has been a huge focus of the pandemic in the last 2 years. Very little until the vaccines came along for prevention. And then, of course, there's a big issue that in the pandemic has also been teaching us that even after you recover from an acute episode, a significant proportion of individuals will continue to have lingering symptoms as far as we can tell, even up to a year. And that means, of course, long-term care, which makes COVID an interesting example of another chronic disease for some people anyway. But also, this is another area which is often completely absent in most healthcare systems, the areas of rehabilitation, long-term care, and palliation, all of which are often left, presumably for families themselves to have to take care of. We have no other questions right now, and I wanted to make sure that, I would like to give a chance also for the panelists to ask questions to each other. So please, Chris.
Sorry, I think that was a wrong button.
Okay, well, still, since the floor is yours, if you would like to ask a question or make an observation, you're welcome to do so now. Well,
I guess in listening to the discussion that's happened so far, my mind is turning back to some of the pandemic preparedness that needs to happen, and it's clear, we've over the last 10 or 15 minutes, we've been talking about the massive effort that's needed to build truly systems that care, comprehensive health systems that are seen as assets that are invested in the way that been described, and that it's clear that having those will enable responding to pandemics to be more effective. And at the same time, I do think that there are, those seem like long-term projects that we need to continue, as a global health community. And coming out of this COVID crisis, are there also kind of turning back to what we need to learn from the pandemic? Actions that need to be taken now to avert this sort of crisis from having and from happening again. And that does come back to some of the things that we touched on earlier, the surveillance systems. And Angela, you were talking about integrating data across so many sectors of government. And I wonder, within your sector and with IDM, thinking that you've had on integrating disease information across countries and across, and particularly in lower income countries, opportunities that exist for doing that more effectively than is done right now.
Thank you, Chris. It's a very, very good question. From a technology perspective, at this point, I think the technologies to connect data across countries in many cases may exist. And some of the early efforts to do that, for example, in Europe, there is the early stages of the European health data space, which is a good example of people trying to connect data they didn't previously connect across geographies. I think that the bigger issue for me, though, would be, well, first of all, there's a question of what governance and stewardship and risk management mechanisms you would have around making that happen, and under which conditions you would get, how would countries align on what is appropriate use and what they're willing to share versus not share. The second part would be, if you think about some of the low and middle income countries, how to strengthen the internal data collection systems that can provide the right information for surveillance purposes, in particular when it comes to remote areas, etc. Again, technologies exist, but it's a question of finding the right funding envelope, creating perhaps an alliance of national, regional, local, international organizations, donors, and others, and looking at how we can come together to support the weakest part of the link in a way, in having at least a minimum standard of collection of the right kind of information that we can then connect across countries. And I think that is, I know it's a big priority area and a big concern for many people in the global health system, including in WHO and other bodies. How do you actually get from where we are today to a place where more information of the right quality is collected more promptly and connected in a way that allows you to see the full picture? But what I can say, though, and I'm going to take the liberty here of talking more broadly on behalf of the tech sector, in an earlier stage, I was supporting the WHO DTAC, the Digital Health Tech Advisory Group, which was basically an advisory group to the WHO CIO at the time during COVID, on how we support health systems, low and middle income countries in particular, in transition into digital first health systems and finding the right solutions they can leverage during the pandemic, as opposed to trying to build from scratch. And what struck me there is that the tech sector was coming together. DTAC was just an example, there are many others, but different companies were coming together in a very selfless way, in fact, to sort of support the thinking and the delivery of the WHO and other bodies in how this can actually happen. And so I think if the willingness is there and the governance and stewardship aspects that countries and international bodies need to address are addressed, I think from the tech side, you will find a lot of support for this.
I'd like to end with, just a final theme that I think many of us have touched on in the last 2 hours, but perhaps we haven't dealt with in depth. And the discussion on technology really reminded me of that. And that is, of course, the question of disparities. We've heard this come up repeatedly in very many different ways to do with COVID-19. But of course, the disparities we've seen in COVID-19, the disparities in access to the vaccine at the global level, the disparities in access to digital technologies for families whose kids were suddenly locked at home and were expected to do education from home, which, in most countries meant no education at all. In India, for 2 years, a significant majority of India's children have gone without any education. What catastrophic implications that has for the future of the country's youth only time will tell. So there's a bunch of different disparities, but of course these disparities didn't occur in the last 2 years. They were just amplified. And obviously one of the big lessons I would imagine we'd all agree about the post-COVID era is that the world begins to look at services, social welfare and healthcare services, which is the focus of our conversation today, through the prism of justice and equity, and that this reduction of disparities is put on the same level as access to these services. That is to say that they are equally important, not just at the average what is happening, but also when you break down the structure of your population into historically disadvantaged groups, that in fact you're also closing the gap between the privileged and the less well off. And I wondered whether anyone would, in the final close, in fact, I'm going to ask each of you to give some final closing remarks because we are coming to the end of our time here. And so I'm going to invite each of you to speak about your thoughts about what the future of the world should look like through the specific lens of creating a fairer, a just, a more equitable world when it comes to health and social care services. Let me start with you, Agnès.
Thank you, and thanks for organizing this great discussion. I think in summary, what I would really like to emphasize is that on one hand, the world is increasingly globalized, which means that the problems we are facing that affect human health are universal. And that if there was a world a few years ago in which there was a rich world and a poor world, this world will no longer exist in the future. We are facing health threats, largely from environmental causes, but also our entire civilization, the way we grow food, the entire food system that we entertain, that is dependent on very few products that are increasingly globalized. We see it with the Ukraine crisis and its impact on food security. That world is global. And globalization in this respect will not go away because climate change and biodiversity loss and pollution are universal. And that is really something that will require global action in the area of global public goods. And that includes R&D, and that includes knowledge creation and knowledge dissemination. And in many ways, this will happen to the new vessels, new vehicles, which happen very fast because of technologies. And we need to have a different way to manage that commonality. We will need to create new institutions or make the myriads, the thousands of institutions that have helped address the COVID-19 crisis. We'll need to make them stronger and add to their interconnectivity and create strong science institutions that can regain the trust of people. But on the other side of the spectrum, so that's the one side where we need to invent a new way to manage the global public goods, like the centralized way with the global architecture as we have it today has been a collective failure. They're no longer adapted to the problems of today. So we need to develop new institutional models at global level. But on the other side of the spectrum, it's really all local, as you have all said very eloquently. It is about building those adaptive community systems that will be able to both prevent and respond to all the challenges that are coming our way, and that will be disruptive to our societies. Whether it is about the weather events, the droughts, the water insecurity, water access, the food insecurity, looming epidemics and pandemics, migration, we'll need to have within our societies the very ways of responding, of preventing and responding to this, and that cannot be centralized. We will really need to invest in a new generation of human capital, in which we have the resources within our communities to address those challenges. So for me, that's really the two ways. It's really about on one hand people locally, and on the other hand new global institutions. Thanks.
Thank you so much, Angela. Sorry, Agnès. I'm going to hand over now to Ben.
Thanks, Vikram. I'll start off with 4 very brief points. I think the piece around health inequalities, I think we need to own and accept that many of the inequalities that we've seen in the last 2 years were entirely predictable. We knew what the challenges were going to be. Honestly, I think it comes down to, did we actually choose to address them and make decisions that would remove those inequalities? And I think we need to learn from that as we look forward. We know where the inequalities will be in health and healthcare in the future. Second point, science, data and technology are coming together like never before. It is such an incredibly exciting time for health and healthcare. We genuinely now have the opportunity to transform, not tinker around with healthcare. And as part of that, we need to really now shift, as I said earlier on, that we view the health of our nation as an asset rather than a cost. And finally, that we really now move to more of a value and outcomes-led healthcare system, rather than one that is typically focused on inputs and volume. We've got to change the expectation there. So I'll just make those final 4 points.
Wonderful, Ben. Thank you. Now, Angela.
Thank you, Vikram. I think the point on inequalities is absolutely fundamental. I had the opportunity to work on that over the last 20 years, particularly within the English NHS, looking at different communities, whether it was socioeconomic communities or ethnic communities that were connected in different ways to the health system. So I think for me, part of the question then on what do we do to reduce inequalities is how do we use the systems we now have to reach the so-called hard-to-reach populations. And if we know there are clusters of populations that have certain characteristics, and we know what they are, we have seen empirically, even before COVID, what the issues were, how do we then programmatically go to the different pockets where this inequality is centered and try to put programs in place that connect people in a different way to the health system, that makes them feel more ownership in their interactions? We understand what the barriers are. In some cases, in my experience in the NHS, was even language. You know, the barriers can be from the more, straightforward to the more complicated, but actually trying to design systems that don't just cater for one particular segment of population, but create a good, I would say, user experience for people within the hard to reach groups. seeing things from their perspective and create the right connectivity with the system. I think getting to that could go a long way towards addressing these inequalities and addressing, to your point earlier, Vikram, some parts of the complexity around mental health and population suffering from, in particular, serious mental illness over time. So I think that all of that aspect is very important. Now, coming back to where we stand today, and just as closing remarks, I would come back to it's very important as we look for additional investment or better use of investment in the healthcare system to come together as a sector and be very clear what outcomes we are planning to deliver. And the honest answer is we cannot do everything all the time. So we will need to do some strong prioritization and then create a narrative and then share it with our stakeholders in society who may be outside of healthcare and say, this is why you have to fund this and this is what we're going to do. I think for me, two priorities would be around, on the one hand, population health outcomes, and on the other hand, personalization through genomics and others. So I would love to see these two agendas progress, but I appreciate there may be others more important in other people's minds. But coming back to this, I think we do need to have more of a plan going forward and not react instinctively to what's priority at any given time.
Thank you, Angela. And the last word to you, Chris.
Thank you, and thanks for the opportunity to be part of this discussion. I would make a couple of points. I think starting with recognizing this kind of juncture or pivotal point that we're in history, and Agnès touched on this, where the multilateral system is very shaken, and I think that without something, the new iteration to replace it, there in many ways is going back to the other alternative, which is kind of nationalism, and you see that that trend happening right now, and I think we need to be to tread very carefully in stepping towards something new, but not totally leaving it until this new way of us working together is created. I think risk falling into something that could be much more destructive if we're not careful how we collectively move forward. On equity, I think this should be front and center, and it comes back to having an outcome and value kind of driven health system. And I think it's very clear that putting equity at the heart of that is a good investment, is one that produces outcomes and is often the most efficient. And if we look at kind of coming back to preventing another pandemic like this, we also need to remember that most of the burden of the current pandemic was borne by people who are the most left out. And so preventing another pandemic from happening and putting in place the mechanisms that we've discussed over these last 2 hours is also a way to prevent that sort of burden from happening again on those sort of populations.
Thank you all. I think with that, it only remains for me to say what an engaging discussion this has been. We've covered so much about the post-COVID era, and I think there's been a lot of convergence actually in many of our observations. I mean, I can certainly think that nobody here disagrees with the need for there to be a reimagination of the architecture of healthcare systems towards the goals of universal health coverage, person-centered care, addressing the care that people need, and that includes extending health to social care as well, and addressing, for example, often neglected issues like mental health, leveraging the resources that communities have, such as community health workers, but also making sure that the additional investments that have been made in historically large amounts in the last 2 years on the vaccines are deployed continuously on building the foundations of the healthcare system. The pandemic may be largely over in its acute phase, but of course, the monies that were made available need to actually be sustained to make sure that we all get the kind of healthcare system that we deserve, one in which everyone, everywhere, is able to achieve the highest standard of health that they're entitled to. Of course, that's the wonderful definition of universal health coverage that that was coined many, many years ago. So with that, thank you all very much. We're exactly at the hour, and I wish you all a wonderful rest of your day.
Thank you.
Thank you.
Thanks, Vikram.